Welcome to the Diva Details. Welcome to the Diva Details, where bold, confident women embrace life unapologetically. From love and sex to wellness and reinvention, we keep it raw, real, and powerful. No filters, no limits. Just fearless conversations to help you thrive. Let's dive in with Diva Mia.
Welcome back to the Diva Details. It's Diva Michelle, and today we're getting into one of the biggest health conversations happening right now: the weight loss medications that have basically become household names. Ozempic, Wegovy, Tirzepatide. That one sold as Zepbound for weight loss and Mounjaro for diabetes. And we're also talking about Metformin and a few other options that are still on the table. And just so you know what kind of episode this is, we're not doing hype. We're doing real talk. What these meds actually do in your body, what side effects are common, which side effects are rare but serious, what starting low, titrating up, and maintenance really look like, what can happen when you stop, and the question I hear constantly: how do you lose weight without looking drained in the face, and how do you keep your skin looking firm? Quick disclaimer before we get into it. I'm not your clinician. This is education, not personal medical advice. If you're on any diabetes medications, or you have a history of thyroid disease, gallbladder disease, kidney problems, or pancreatitis, you need medical guidance before starting or changing anything. Alright. Big picture first. The modern weight loss medication wave is largely driven by a class called GLP-1 receptor agonists. In plain language, these medications mimic a natural gut hormone involved in appetite and blood sugar regulation. The headline effects are pretty straightforward: you feel full faster, the constant cravings can quiet down, and your stomach empties more slowly, so that "I'm satisfied" feeling lasts longer. Then came what a lot of people consider the next big step: dual incretin therapy. That's Tirzepatide. It works on two receptors, GLP-1 and GIP, and for many people that combination is part of why the average weight loss numbers can be higher. But keep in mind, everyone responds differently. Two people can take the same medication and have totally different outcomes. Now, one thing I want to make very clear: these weren't created as vanity diet drugs. They were developed for metabolic disease, and the weight loss is tied to how they change appetite signaling and glucose regulation. Here's the FDA-approved landscape in a simple way. Ozempic, which is semaglutide, is approved for type 2 diabetes, and for cardiovascular risk reduction in certain patients. Wegovy is also semaglutide, but at a higher dose specifically approved for chronic weight management. Zepbound is Tirzepatide approved for chronic weight management. Mounjaro is Tirzepatide approved for type 2 diabetes. And yes, there's also an oral form of semaglutide on the market, and there's even newer movement in that space. Let's also talk about who makes what, because the manufacturer matters for authenticity and safety. Semaglutide products like Ozempic, Wegovy, and Rybelsus are made by Novo Nordisk. Tirzepatide products like Mounjaro and Zepbound are made by Eli Lilly. Saxenda, which is liraglutide, an older daily GLP-1 used for weight loss, is also Novo Nordisk. Contrave, which is naltrexone plus bupropion, is distributed by Curex. Simia, which is phentermine plus topiramate extended release, is another long-term FDA-approved option that clinicians use commonly. Orlistat exists as prescription Xenical and over-the-counter Ali. Plenity is different. It's not a drug at all. It's an FDA-cleared device, basically a hydrogel that takes up space in the stomach to help with fullness. And Metformin is the classic older, widely used generic medication for insulin resistance and type 2 diabetes, and it's sometimes used off-label in weight management. So what do these meds actually do in the body? Let's translate the science without making it a pharmacology lecture. Semaglutide, meaning Ozempic and Wegovy, activates GLP-1 receptors. That leads to more insulin release when your blood sugar is high, less glucagon in a glucose-dependent way, slower stomach emptying, and a noticeable reduction in appetite and what many people call food noise, that constant mental chatter about eating. Tirzepatide, meaning Zepbound and Mounjaro, activates both GIP and GLP-1 receptors. For a lot of people that means stronger appetite suppression and larger average fat loss over time. But again, it's individual. Some people do amazing on semaglutide. Some do better on Tirzepatide. Some can't tolerate either. Metformin is a different vibe. It's not an appetite injection. It mainly works by lowering how much glucose your liver produces and improving insulin sensitivity. It also affects the gut in ways that may influence GLP-1 signaling and the microbiome. People sometimes lose a little weight on it, especially if insulin resistance is a big driver, but it's not in the same category as GLP-1 medications. And I want to say this clearly: if GLP-1s aren't available, aren't affordable, or just aren't tolerated, there are still FDA-approved alternatives like orlistat, Contrave, and liraglutide. Different tools, different mechanisms, different pros and cons. Now let's get into side effects, because this is where people either feel prepared or get blindsided. The most common side effects with GLP-1s and tirzepatide are gastrointestinal. Nausea, diarrhea, constipation, reflux or indigestion, vomiting, abdominal discomfort, and just not wanting to eat. And here's the pattern: side effects tend to spike when the dose increases. That's why going slowly matters so much, even if you're impatient and want the scale to move yesterday. But we also need to talk about the uncommon but serious risks. Semaglutide and tirzepatide carry a boxed warning related to thyroid C-cell tumors based on rodent studies. These medications are not for you if you have a personal or family history of medullary thyroid carcinoma, or if you have men too. That's not a maybe. That's a hard stop conversation with your clinician. Pancreatitis is rare, but it's serious. Severe upper abdominal pain that doesn't let up, pain that radiates to the back, persistent vomiting. This is not the time to tough it out. That's the time to get checked. Gallbladder issues are also important. Rapid weight loss on its own increases the risk of gallstones. And GLP-1 medications have been associated with gallbladder events for some people. Some people end up with severe problems, and yes, some people end up getting their gallbladder removed. If you're having right upper abdominal pain, especially after eating, nausea that's different than your usual medication nausea, or symptoms that feel alarming, don't ignore that either. Kidney problems can happen indirectly, especially if nausea, vomiting, or diarrhea leads to dehydration. If you're someone who gets dehydrated easily, or you already have kidney issues, this needs to be monitored. Along the same lines, severe slowing of the stomach can look like gastroparesis-type symptoms. Constant fullness, inability to keep fluids down, or severe constipation that's not improving is not something to self-manage forever. You need medical guidance. What about the other weight loss medications? They have their own baggage too. Contrave can cause nausea, headaches, constipation, and insomnia, and it can feel activating for some people. Semaglutide can cause tingling sensations, dry mouth, and insomnia, and it has very serious pregnancy-related warnings. Orlistat blocks fat absorption, which sounds simple, but the gastrointestinal side effects can be very intense if your diet is higher in fat. Plenity can cause fullness and bloating, but since it's non-systemic, some people prefer that approach. Metformin commonly causes gastrointestinal upset, and there's a rare but serious risk called lactic acidosis, especially in higher-risk situations like kidney impairment, heavy alcohol use, dehydration, or acute illness. Now let's talk about what the process actually looks like when people say, "I'm starting." Because a lot of people imagine it's one shot and suddenly everything changes. That's not real life. Phase 1 is the start-low period, sometimes people call it loading. You begin on a low dose so your gastrointestinal tract can adjust. You stay there long enough to see how your body responds and whether side effects are manageable. Phase 2 is titration, meaning gradual dose increases over weeks. The goal is to climb in a way your body can tolerate. And if your side effects flare, clinicians often pause the increase, hold the dose longer, or sometimes step down temporarily. Going faster is not always better. It can actually backfire if you end up miserable, dehydrated, or unable to eat enough protein. Phase 3 is finding your effective dose. This matters because not everyone needs the highest dose. The goal is usually the lowest dose that still gives steady fat loss with side effects you can live with. And phase 4 is maintenance. This is the part that people don't love hearing, but it's important. Obesity is chronic. For many people, stopping these meds leads to weight regain. That doesn't mean you're weak or broken. It means your biology is doing what biology does. Maintenance can look like staying on a stable dose long-term, or stepping down carefully to the lowest effective dose, while doubling down on lifestyle habits. What makes sense for you is a decision for you and your prescriber. So how do you keep the weight off after you've done all that work? Whether you stay on medication or not, your body needs a new normal, not just a temporary sprint. Number 1, protein and resistance training. I will say it again and again because it matters: lift weights. Protecting muscle is everything. The more muscle you lose, the easier it is to regain fat later, and the harder it is to maintain your results. Number 2, create a weekly structure. A plan beats vibes. You don't need a perfect spreadsheet, but you do need a rhythm: what you eat most days, when you shop, when you train, what your high-protein staples are. That structure stabilizes appetite and keeps you from living in decision fatigue. Number 3, sleep. Lack of sleep ramps up hunger hormones and cravings, and it can increase inflammation and water retention too. People underestimate sleep because it's not as exciting as a new medication, but sleep can make or break your progress. Number 4, fiber and whole foods still matter. Even if your appetite is lower on a GLP-1, fiber supports your microbiome, regularity, and steadier hunger signals. It also helps you stay well-nourished on fewer calories. And number 5, the reality check. If you stop the medication, appetite often comes back. Sometimes it comes back loud. So don't plan to rely on willpower in that moment. Plan on structure. Plan on protein. Plan on training. Plan on meals that don't leave you starving an hour later. Now let's get into the topic people whisper about but everyone is thinking about: skin changes, skin laxity, and what people call Ozempic face. Here's the truth. Skin looseness is usually about the speed of loss, your age, your genetics, your sun exposure history, and how much muscle you keep while you're shrinking. So what actually helps your skin look firmer while you're losing weight? First, consider slowing the pace if you're dropping extremely fast. Rapid loss tends to make laxity more noticeable. Sometimes dosing, nutrition, or the overall plan needs adjusting so you're not falling off a cliff. Second, lift weights. Muscle is like internal shapewear. It gives your body more structure under the skin, and it helps keep your shape looking athletic instead of deflated. Third, prioritize protein. Protein supports collagen and helps you hang on to lean mass. Your exact needs vary, so a clinician or dietitian can personalize grams per day, but the principle stands. Low protein plus rapid weight loss is not the combo you want if you care about your shape and your skin. And then the basics that truly matter for skin support: adequate vitamin C, because it's essential for collagen formation, hydration and electrolytes so you're not chronically dried out, and avoiding extreme undereating. Also, simple daily skincare habits help more than people want to admit. Moisturize consistently. Protect your skin from the sun. If a retinoid makes sense for you, use it gently and consistently, not aggressively and randomly. Professional treatments can help too, like radiofrequency, microneedling, or ultrasound-based treatments, but timing matters. These options often work best after your weight has stabilized. If you're still actively losing, you may be paying for results that you're going to shift right past. And let's just normalize this: Ozempic face is often just rapid fat loss in the face. The fix is not panic. The fix is a smarter pace: keeping muscle, eating enough protein, and not trying to lose 40 pounds in 8 weeks unless there's a medically necessary reason and you're being monitored closely. Before I wrap up, we have to talk about safety in the real world. There's been a major increase in compounded or counterfeit GLP-1 products sold online. The FDA has warned about unapproved compounded semaglutide and Tirzepatide, including dosing errors and products that aren't what the label claims. If you're seeing something that feels too good to be true, like miracle pricing or mystery sourcing, please slow down and be careful. With these medications, dosing accuracy and authenticity are a big deal. So here's the bottom line. These medications can be life-changing tools, especially for metabolic disease and chronic weight management. But they are not magic. They require a plan, a smart titration schedule, side effect management, hydration, protein, strength training, and a long-term maintenance strategy that respects biology instead of shaming it. If this episode helped you, Share it with a friend who's been quietly curious but overwhelmed by the internet noise. Stay bold, stay informed, and take care of your body like it's your home. This is Diva Michelle, signing off. Have a great week. And one last medical note, this episode was education, not personal medical advice. If you're considering these medications, talk with a licensed clinician, especially if you have any history of thyroid cancer, pancreatitis, gallbladder disease, kidney disease, if you're pregnant or trying to become pregnant, if you have an eating disorder history, or if you take medications like insulin or sulfonylureas.
Thanks for tuning in. Like, subscribe, and drop a comment. We love hearing from you. Visit thedivadetails.com to connect. See you next week for more.
Diva Details podcast and website are intended solely for informational and entertainment purposes. The content provided does not constitute professional, medical, financial, or legal advice. We are not licensed medical practitioners, financial advisors, or legal professionals. Always consult with a qualified healthcare provider for medical advice, diagnosis, or treatment. Any financial topics discussed are based on personal opinions and experience and should not be considered professional advice. The content provided does not constitute legal advice. Diva Details and its affiliate contributor and guests are not liable for any losses or damages arising from the use of our content. The opinions expressed in the podcast are solely those of the speakers and do not necessarily reflect the views of any affiliated organization, sponsors, or partner. All facts discussed in the podcast are researched and accurate to the best of our knowledge at the time of recording. Information may change over time. No guarantees are made regarding the accuracy, completeness, or reliability of any statements or opinions presented. It is the responsibility of the listener to verify any and all facts that may influence their decision. This podcast is for information and entertainment purposes only and should not be considered professional advice.